Hey class, I'm going to be discussing competence to consent to research, which can be found in the textbook on pages 379 to 382. What is competence to consent to research? It is consent to participate in a research trial, whether the treatments are in a psychological setting or in a medical setting. So, social and behavioral science, their risks are different compared to the ones done in a biomedical setting. With social and behavioral science, they carry little to no risk, but with the biomedical setting, research often does represent significant risks. This means that there are serious ethical problems when research is practiced on people with questionable competence. Like with all research projects, there are legal requirements. This originally started with the Nuremberg Code that was enacted after what happened in Nazi Germany during World War II. It established a legal framework by prohibiting any research using people who can't give informed consent. And the United States human research is regulated by the Department of Health and Human Services, which also require that participants give informed consent. On top of that, local institutional review boards review all of the human research that happens in the US. There are 8 required regulations that experimenters must follow. They range from a statement of the study, the risks, the benefits of the research, appropriate alternative procedures, confidentiality of records of the subject, if more than minimal risk is involved, a contact for answers if the subject has any questions, and a statement that participation is voluntary. On top of that, there are 6 additional regulations that are applied when appropriate. These regulations range from risks if the subject is pregnant to the approximate number of subjects that are in the study. All 6 of the regulations can be found on page 380 of the textbook. The IRB may waive the requirements for full disclosure if research involves no more than minimal risk, and this is known as the minimal risk waiver. In the textbook, minimal risk is defined by the probability and magnitude of harm or discomfort anticipated in the research no greater in and of themselves than those ordinarily encountered in daily life or during the performance of routine physical or psychological exams. The HHS also provides special requirements for participants of uncertain competence. For example, prison inmates are forbidden to be used in research studies due to the possibility of corrosion being involved. With children, it is required that the experimenters get permission from the parents before proceeding on with the research. Research involving psychiatric patients have never been given specific regulations. However, it does follow the general regulations and informed consent from either the patient themselves or their legal representative is required. Empirical research on the competence to consent to research has grown substantially since the mid-1900s. Several research measures have been developed that specifically assess various abilities relevant to competence to consent to research participation. People with serious disorders perform poorly on structured measures of capacity compared to subjects with no mental illness. People with mild, moderate Alzheimer's disease perform poorly in absolute terms and in comparison to people with schizophrenia, while subjects with schizophrenia perform more poorly than people diagnosed with depression. And then people with depression often show good competence-related skills. Many people with various mental disorders display impaired capabilities relative to subjects with no mental disorders. People with disorders such as schizophrenia and depression display competence-related abilities that are comparable to individuals without mental disorders. Studies that were done on major mental disorders and the more severe symptoms of them show that the performance actually worsened on the measures of competence-related abilities. And then studies also showed that impaired competence is linked more closely with cognitive deficits rather than to symptoms like hallucinations. This made Carpenter and colleagues note that the findings agree with the common clinical observation that the degree of psychotic symptoms, except at the extreme, does not robustly predict patients' functionality in their daily life. Poor performance on competent measures can actually be remediated by educational interventions. This means that individuals with mental illnesses should not be considered incompetent because of an initially poor performance on a screening assessment. Instead, they should be brought back in to, get a better understanding of the research project that they want to participate in. Early research suggested that competence of elementary school age children were not less competent than adults at understanding the research, and that children were more likely to stop participation if they were told that the experimenter would not be upset if they did. It is important to provide these educational interventions due to the fact that many participants actually do not understand that they are a part of a research study. Instead, they think it is part of their, normal treatment that they have to go through. The risk assessment is different from the consent to treatments risk assessment. This is because risks in research projects are generally unknown. The textbook has a really good example of this with the first humans to receive an experimental drug. They can be told what kind of risks were found in the animal portion of the study, but until they take that specific drug, they won't know what the side effects or what the risks of taking that drug would be. Motivation for research consent could also differ from the consent to treatment because it is possible that compensation might trump other factors in a potential subject's decision to be involved in the study, and they don't actually reflect on what kind of risks, if any, are involved in being a part of the study. The evaluation to show if someone is competent enough to consent to research actually mirrors the evaluation of treatment consent. However, clinicians should also evaluate the nature of the research opposed to treatment like in the treatment consent. And they need to specify to the participants that there is a freedom to withdraw from the study. Dunn and colleagues found that the MacArthur Competence Assessment Tool for Clinical Research, also known as the MAC-CAT-CR, was the best instrument to use when assessing if someone is competent enough to consent to research. The MAC-CAT-CR assesses competence-related abilities such as understanding and reasoning, but it also must be constricted according to the nature and the details of the proposed research. And it is always important to make sure to document the informed consent process when recruiting participants. If you're curious to know about the different guidelines to follow to get informed consent in a research study and to make sure it is actually informed consent and you're not doing something illegal, this is a good website to go through. It is more of a visual guide as opposed to technical terms like the ones found in the textbook, so I feel like it's easier to follow. And finally, the discussion question. I'm curious to know that if you were in a research setting, how would you make sure your participants are competent to consent to the research and they understand their role in the project? And then these are my references. Obviously, I use the book, and then there is the reference for the informed consent guideline. Thanks, guys.